Hello, Mr. Lee. I'm the attending physician. The nurse mentioned you have been vomiting severely. How many times have you had diarrhea since this month?
About 7 or 8 times already. I feel so dizzy and weak.
I'm going to do a simple palpation now. If you feel uncomfortable anywhere later, just let me know.
Okay.
Okay, take a deep breath. Does it hurt when I press here?
Oh, yes. It hurt really bad.
I see. You have lost a lot of weight recently, haven't you? According to your charts, you have lost 25 pounds in the last 9 months.
Yes, I have Crohn's disease. I have had 2 surgeries to remove part of my intestine. Since then, my absorption has been terrible.
You are severely dehydrated. Since your body can retain fluids or nutrition orally right now, we need to insert a central venous catheter.
Do I need to be hospitalized?
Yes, we will insert a tube through the internal jugular vein in your neck. This will allow us to provide parenteral nutrition directly into your bloodstream, or your body won't be able to recover. Mr. Lin, the reports are in. To put it simply, your current condition is a vicious cycle caused by an acute flare-up of Crohn's disease combined with Strawberry syndrome.
Doctor, why is this happening? I've been trying to eat.
Crohn's is an autoimmune issue that causes chronic inflammation in your digestive tract. It's like a wound that never heals. Because your previous surgeries removed a large portion of your small intestine, what's left is too short to absorb enough nutrition.
So, that's why I keep having diarrhea?
Exactly. Food passes through before it can be absorbed. This is Strawberry syndrome. Right now, your bowel needs rest. We can rely on oral intake, so we will provide nutrition directly into your vein via this neck catheter.
Weight and abdomen. At 5 feet 10, he weighs only 120 pounds. His BMI is dangerously low. The mass and pain in his lower right abdomen reflect inflammation in the terminal ileum. Hemoglobin. A normal male range is roughly 14 to 18. His level of 10 indicates anemia, as his gut cannot absorb iron or vitamins. Serum albumin. The normal levels should be about 3.5. His serum albumin level at 3.2 indicates severe protein malnutrition, which leads to weakness and poor wound healing. RBC and hematocrit. Both are low, showing chronic blood loss and a lack of resources for the body to produce new blood cells.
Mr. Lin, your albumin and hemoglobin level are very low. That is exactly why you feel so exhausted. We will replenish this through the IV first, and once the inflammation settles, we will discuss the next steps.
Thank you, Doctor.
I'd like to explain about RLQ and diffusing abdominal pain. The right lower quadrant, or RLQ, mainly contains the appendix, the terminal ileum of the small intestine, and part of the cecum, which is the beginning of the large intestine. In some cases, structure like the right ureter may also contribute to pain in this area. Clinically, pain in the RLQ is often associated with conditions such as appendicitis or disease affecting the terminal ileum, like Crohn's disease. Diffusing abdominal pain is mainly due to how pain is transmitted in the body. Early in many abdominal conditions, pain is carried by visceral nerves, which are not very precise. As a result, the brain cannot accurately identify the exact location, leading to a vague, poorly localized pain sensation. As the condition progresses and inflammation reaches the parietal peritoneum, which had more precise sensory innervation, the pain becomes localized and sharper. A classic example is appendicitis, where pain starts around the umbilical region and later shifts to the RLQ.
Following up on the anatomical causes of our patient's right lower quadrant pain, let's zoom in and take a closer look at the cross-sectional anatomy of the intestinal wall. As a quick overview, the intestinal wall is essentially a 4-layer tube from the inside out. We have the mucosa, the submucosa, the muscularis, and the serosa. So let's break them down. The innermost layer is the mucosa. It is covered in countless intestinal villi, acting as the primary front line for digestion and in nutrient absorption. Just beneath it is the submucosa. This layer contains a rich network of blood vessels, lymphatics, and nerve plexuses to transport the absorbed nutrients into the systemic circulation. Further up is the muscularis layer. It consists of an inner circular muscle and an outer longitudinal muscle layer, which work together to drive intestinal peristalsis. And finally, the outermost layer is the serosa, providing a smooth protective covering.
Having mastered these four fundamental layers, let's examine how these structures collaborate physiologically to carry out complex nutrient absorption.
At the cellular level, enterocytes are responsible for absorbing nutrients. Glucose and amino acids are transported into epithelial cells and then enter the capillary network, eventually reach the liver through the hepatic protocirculation. Lipids, on the other hand, are absorbed, reassembled into chylomicrons, and then transported via the lacteal into the lymphatic system. However, when disease strikes, the accompanying severe inflammation blunts and destroys the mucosal villi, while infiltrating into the submucosa to cause wall edema, which plunges the entire absorption system into a functional collapse.
To address this systemic collapse, in this specific case, the patient underwent 2 previous resections of his small intestine, leading to a tract length is significantly shorter than the normal 9 meters. Primarily, the reduced intentional length and the shorter pathway drastically impair the body's capacity for nutrition and water reabsorption. As we can see in this picture, there is also rapid intentional transit. Many food and fluids move through the system too quickly to be absorbed properly. This situation not only causes nutrient loss, but also disrupts the system balance due to the decrease in electron pumps. The consequences are severe, including extreme dehydration and a drastic weight loss. In the case, 25 pounds lost within just 9 months.
To bypass the falling guts, we provide nutrition via central venous catheter, typically via the IJV or SCV. Now, I will introduce the anatomy and clinical relevance of the internal jugular vein. First is origin, course, and termination. The internal jugular vein originates from the jugular foramen, descends along the neck, and joins the subclavian vein to form the bastiocephalic vein, which drains into the superior vena cava. Next is spatial relationships. It lies within the carotid sheath, lateral to the common carotid artery, and is covered by the sternocleidomastoid domestic muscle. Clinically, it is accessed between the 2 heads of this muscle. Finally, the anatomical basis for catheterization. It is superficial, easy to locate, and provides a straight path to the superior vena cava, with a lower risk of pneumothorax than the subclavian approach.
Now, tracing laterally from its junction with the internal jugular vein, we arrive at the subclavian vein. The subclavian vein is a major deep vein of the upper thorax. It begins as a continuation of the axillary vein at the lateral border of the first rib. It then arches medially and anteriorly, passing behind the clavicle. Its journey ends behind the sternoclavicular joint, where it joins the internal jugular vein to form the brachiocephalic vein. Understanding its neighbors is crucial. The subclavian vein lies anterior to the anterior scalene muscle, which separates it from the subclavian artery and the brachial plexus located posteriorly. Inferiorly, it rests on the first rib and the cupula of the pleura. The phrenic nerve also passes posteriorly to the vein as it enters to the thorax.
Regarding the localization of deep veins, clinical practice integrates surface anatomical landmarks with ultrasound guidance. Taking the internal jugular vein as an example, when the subject's head is rotated 45 degrees to the contralateral side, The space between the sternal and clavicular heads of the sternocleidomastoid muscle forms the supraclavicular minor fossa. The IJV and the common carotid artery reside in this deep region. Due to its superficial location and absence of skeletal obstruction, this site facilitates both puncture guidance and manual compression for hemostasis. The right IJV is clinically preferred for two primary reasons. First, the right-sided venous anatomy provides a straighter path directly into the superior vena cava, significantly enhancing the ease of catheter advancement. Second, this approach avoids the thoracic duct located on the left, thereby mitigating the risk of inadvertent injury and subsequent cardiothorax. The subclavian vein lies posterior to the clavicle. It is usually accessed about 2 cm lateral to the junction of the medial and middle third of the clavicle, with the needle directed toward the suprasternal notch. Because the clavicle overlays the vessel, external compression is difficult, making hemostasis challenging. It is very close to the lung apex and pleura, so there's a higher risk of pneumothorax if the needles go too deep or too low. Both catheters finally drain into the brachiocephalic vein and then into the superior vena cava, where the large vessel diameter and rapid blood flow allow for the swift dilution of the hypertonic parenteral nutrition solution required for this patient, effectively preventing local phlebitis and thrombosis.
Doctor, now that the catheter is in place, how will the treatment proceed?
Once your bowel has rested and your electrocytes have stabilized, we will proceed with medication or surgery to address the intestinal inflammation.
Thank you so much, doctor.
You're welcome.